Dr. Zoltan Nyarady, Master of Dentistry, Doctor of Dental Surgery, Oral and Maxillofacial Surgeon, guest lecturer at the University of West Hungary, national speaker of IBS Implant in Hungary. Dr. Zoltan, the floor is yours. Please welcome.
Thank you very much. Let me begin sharing. Do you hear me well?
Yes, we do.
Okay, this is a great honor to be here in this AMI organized meeting. This is nice to meet you in this seminar due to the COVID-19 infection. Hope that the hard times go fast and we can meet in person soon. It is good to see you in later events also with AMI. Let's introduce myself. I'm an oral maxillofacial surgeon based in southwest Hungary, in Győr, halfway between Budapest and Vienna, the capital of Austria. We just opened our practice with my wife and co-workers in March last year. The COVID also hit us hard, but luckily we were prepared for technically to treat complex cases, so we could easily cope with the changing regulations and could begin to give emergency treatment to patients. For the last 4 weeks here in Hungary, the things are getting back to normal and everything seems to be working, so we could proceed with normal treatment of our patients. This is how we work now. On the previous picture, you've seen us how we were working previously. And I also do work on a couple of other places, not on the sea. Something was mixed up here. I'm working in Hungary, a couple of places, and I do work in Norway in 3 places. Unfortunately, for the last 3 months, I couldn't go to Norway. They still impose a 10-day quarantine before you can work there. So my next trip there is planned in something like a month, and hopefully by that time, as Europe opens, we can also work there. This is my office. In this office, I work regularly, and I exclusively do use IBS implants. At the beginning, I was using for the last 3 years IBS FC implants, and for the last year, I began to use the MAGICORE also. I have to know that I was using the instrumentation of IBS for more than 6 years by now. Today, I will speak about MAGICORE. My job is difficult as the first speaker because I will have 2 excellent speakers after me, and they will go into different details and aspects. We may have some overlap, but they will give you on those fields much more insight. I will tell you and introduce you the MAGICORE. I also have to tell that this is not only a fixture, this is a whole system, and this is a whole concept of how we think about implants. I will introduce you first the company, then we go through a little theoretical part, then we go to the fixture itself, and then I will try to give you a couple of tips. What are the advantages and why to use the MAGICORE implant? The company of IBS Implant was founded in 2008. It got the key FDA certification the next year. It began quickly expand to Pakistan, Iran, and Turkey. They have had the first IBS symposium in Turkey in 2013. They've continued further expansion. They are in China. They do have subsidiaries in China, Europe, in the United States. And in 2017, they founded AMI. In 2019, they already had the 5th AMI World Symposium in Seoul. This was a great event. It was really good to be there. And last year, they also established a subsidiary in Vietnam. They have plans that this year they are opening a factory in the United States, and they are involved in multiple research projects all over the world, in the United States, Europe, Russia, and hopefully soon in Hungary too. What you have to know is the company itself is located in Daejeon, Korea. The production line is an industry standard high-tech line. It has several random and systematic manual and automatic quality check procedures incorporated into the whole process of producing the implants and the tools. The products were SIA FDI certified and also comply with Chinese standard. The latter is quite hard to get because China itself is a very protective country when it comes to import things to them there. So actually it's harder to get Chinese registration than anywhere else. They also received numerous awards for innovation within and outside Korea, among others, the most innovative patent, which is related to the MAGICORE implant, which we are talking about today. They are also recognized as holders of the fourth original patent within implant dentistry. And they are recognized United States, Europe, and Korea as the first premium brand implant. And I have to note here that in Korea, they are the first second used implant. And this is something big to a company which is not so old compared to the competition. How good is the product? How good is MAGICORE? You can see on this picture. If you take a look, you can see Dr. Wang, the founder of the company. And it is noted where the speakers from. They quickly managed to grab leading opinion leaders and speakers from Zimmer, Hemlock, Straumann, Nobel, and they very fast get a good working relationship with several universities within Europe. In 2017, OMI, the Academy of Minimally Invasive Implantology, was founded. This is an umbrella which incorporates all education, research related to MAGICORE. They had very good seminars. I happened to attend with my colleagues here, and a couple of very nice world meetings and local meetings. And they were responding very much to the COVID threat, also to holding several European, American, and Asian webinars and webinar series during these hard times. So let's my real lecture begin. The original Brönemark implant in 1965 was a result of serendipity. It was a machine-surfaced implant with an outer hex connection on a titanium screw. This is, we can tell, as the first implant, the first paradigm within implantology. The system laid down the foundation of today's implantology, but it needed improvement. The system had its bits: cortical bone resorption, screw loosening. In 1986, ITI designed a new tissue-level implant. The system had also its bits: cortical bone resorption, screw loosening. This solved some of the problems, but it was still there. In 1989, Astra introduced micro threads on the neck of the implants. This way they could handle better the cortical bone resorption around the neck of the implant. They also had a much more stable conical connection, which helped with the micro gap and the micro movement, but still retained the problems with the original implants. And in 2013, MAGICORE was introduced. This is a single-piece implant, which, due to the unique being a one-piece implant, attacks all the problems with screw loosening and all the problems with an abutment. It has a very nice surface treatment, which is industry standard. So basically, the SLS surface works very well, and due to a unique thread design, it handles much better in bone than the previous implants. This is what I will speak about, and this is regarded as the fourth paradigm within implantology. The implant itself has a minimum post height, which is 2 millimeters. It has a variable cuff length, which is 1 to 4 millimeters, and it has an innovative thread for stress distribution. We'll speak about it today. It also has an external and an internal connection, which makes the MAGIC abutment a special connection. Let's go a little bit into implant design. If you go back to the original Brennemark protocol, all the steps which today's the basics are today's implantology were already described and produced. The drawback of the original Brennemark protocol is that we have to have 2 PACE implants. That means we have to open the area 3 to 6 months after the healing period with another surgery. And this meant 2 surgeries to patients. And we also had this way more discomfort and more post-operative morbidity for our patients. In the next slides, I will go through the advantages of, In the next slides, I will go through the advantages of MAGIC cuff and the one-piece implant. You will hear a full lecture more in detail about it from Dr. Burhonsyi, how the soft tissue is handled by the implant. Before we continue, let's take a look of the anatomy of the gum around the teeth and the implants. Here is a tooth, here is an implant. The junctional epithelium is attached to the teeth by hemidesmosomes, both in the case of a tooth and an implant. This junctional epithelium functions as a barrier between the outside world as the bone. It can be easily penetrated by a probe down to the bone, even in the case of a tooth, but it's much more vulnerable in the case of an implant. If you use a 2-piece implant, the junctional epithelium detaches from the abutment, resulting in a deepened sulcus due to the micro movement and due to the fact that we also change this part during the procedure while we make our crown. This will result in gum recession and the connective tissue gets destroyed and we will end up with peri-implantitis. How it's happening? On the right photo, you can see a detached peri-implant epithelium. This happens when the abutment or the healing abutment is removed. In cases of a 2-piece implant, after soft tissue healing, when we take impression, the healing screw is removed. The wound is exposed and we begin to manipulate near to the bone level. The newly developed hemidesmosomes connection of the junctional epithelium is destroyed. The junctional epithelium is detached. Connective tissue is lost around the implant. When we reattach it, it will reattach, but it will go deeper. We have to do it at least twice, if not 4 or 5 times during a more complicated procedure. For example, when we make bridges, and this will result in undergrowth and deepened sulcus around the implants, rising the problems. If you look at the literature, it is shown that abutment and disconnection and reconnection significantly affects the peri-implant bone levels. If we use a 1-piece implant, we do not need to remove the healing abutment, as with 1-piece implant, we preserve the sulcus depth, we will have a complete connective tissue adhesion, and we will reduce the risk for bacterial penetration. This is also supported by the literature. When the implant is inserted, the soft tissue is growing into the fold, which is determined by the emergence profile of the MAGIC cuff. It will heal optimally. we will have a heavy-endosomal connection to the titanium surface, and this will be not disturbed in further handling of our implant when we build up the prosthetic parts. We will maintain ideological biologic weight, and once the crown is seated, we can see on growth, which is basically the formation of a natural sulcus very similar to that around the tooth. This is also supported by the literature that the gum margin is located more coronally, and the biological dimensions are more similar to natural teeth around 1-piece non-submerged implants compared to either 2-piece non-submerged or 2-piece submerged implants. So it doesn't matter if you submerge or not submerge the implants, even in the case of ITI, which is a surface level implants, you will have some problems with your gum. When we compare the conventional implants to MAGICORE, the conditions differences of the soft tissue around the implant are paramount. In case of conventional implant, the sulcus is located between the connective tissue and the abutment, resulting in a deep sulcus, and that forms aging parodontal conditions, resulting gingival recession and the possibility of infection. In case of MAGICORE, the sulcus is located between the connective tissue and the crown. It resembles the healthy periodontal conditions around natural teeth. There is no gingival recession, and chances for peri-implantitis are more than tenfold decreased. After implantation, 4 months. This is immediately after implantation, 4 months, and 6 months with the final restoration. You can see the initial line of the gum. You can see the on-growth because the gum around the implant is not disturbed. There is no micro movement and no micro leakage. From soft tissue, let's move over to bone. Available bones sometimes make surgery challenging. Traditionally, to cope with unfavorable ridge, we have the possibility to use GBR, or we can remove the cast in case we have changes in the crest. And there's also a possibility to use a change shape of the implant. In case of narrow bone, one may use GBR. We may use a narrow implant, but then we have to be aware that we will have some durability consideration, and also this functional surface will be smaller. If the available bone height is not enough, one may use a GBR in a form of a sinus lift, open sinus lift in the upper jaw, or in the lower jaw, the sausage technique by Dr. Orban. Or we can use a short implant, but then we have to consider a bone amount which is actually supporting our implant. One way to fight this is, and avoid all the compromises, that we match the implant to the patient's bone. The bone and gum above the fixture is considered as a soft tissue. That means we'll need several types of heights for this implant. You can see that this amount of bone above the fixture is different height on the X-ray too. Using a strong connection, a bone-driven concept can be applied. The implant and the crown may be angulated, and we change from a prosthetic-focused to bone-focused implant insertion. We will need to design our rehabilitation still from crown down, but our surgical possibilities will be drastically improved. Issues may arise from the location and angle discrepancies between the bone and implant and our prosthetic components. Clinically, The shape and location of the crown is determined outside the soft tissue, or problems may arise from the existing abutments. What we do have here, that if you do have protruding abutments, it will limit our prosthetic way of rehabilitation. To solve this issue, the abutment should be designed not to protrude outside the gum. The MAGICORE abutment is formed. This is a hollow connection. When we use a cemented crown, more than 50 degrees of maximum angulation of the crown is possible, and we will just need a mere 3.5 millimeter of bone level compared to 5 millimeters when using a traditional implant with a cemented crown. And then also the maximum angulation of the crown is less than 35 degrees. When using the screw-retained restoration, the prosthetic advantages are even more profound because of the hollow design of the connection. No forces are transferred to the screw. Therefore, the screw is smaller. The hole for the screw is smaller. There are no micro movements, no loosening and fracture of the screw, while needing drastically less prosthetic space, allowing larger angulations and angulation differences. We will have a strong connection. If we have a strong connection, we will be able to have a couple of advantages. In cases of conventional implants, we do have an external or an internal connection. In the MAGICORE, we don't have it, so we will not have micro movement, we will not have micro leakage, and this facilitates healing while avoiding a lot of problems like screw loosening, the bone resorption around the implant, and downgrowth of the soft tissue. At the abutment level, we will have an external connection with its space and force limitation. The MAGICORE will have both an external and internal connection, a so-called hollow combined connection, giving lots of advantages. What are the advantages of this hollow connection? It gives the best of both connections. The internal part has an anti-rotational effect, has an increased resistance to lateral forces, while the external connection prevents wedging and gives structural durability. Now with the MAGIC abutment, connection of a bone-driven implant placement is possible. We have much more options to produce cemented or screw-retained restorations on our implants. With the MAGIC abutment, we have a connection with outstanding durability. The ways of prosthetic restorations are the same as with traditional implants. We still have the possibility to make cemented restoration, screw-retained restoration. We can work digitally. We can work the traditional way. So basically the same system, the system works as with the case of a normal implant. If we compare it to the literature and the competition, Noble come up with the 1-1 system. It has only a 25% angulation. This is screw retained. So you still have screw loosening and micro leakage problem at the implant level. It has only 2 heights, 3 platforms, and this is still a 2-piece. Also, one has to know that this has lab restrictions. So if you want to work with this system, you have to use the Noble laboratories to work with. Ontogel, which is a Straumann company now, in 2017 also come out with the Axiom TL, which stands for tissue level. They have a unique platform, which has its advantages, but also it's limited to 25% angulation deviances. It is still screw-retained restorations with all the problems of it. It is has 3 heights, 2 platforms. You can get it both on 1- and 2-piece implants, but it still has some laboratory restrictions. And then look at history, and I tell you history because MAGICORE came out in 2013. It has a much higher angulation depending you make a screw-retained or a cement-retained bridge or crown restoration on it. You can have both screw and glue retained restoration. You have 4 height variations. You have 2 platforms. This is a one-piece implant. No lab restrictions, so you can work with any lab you'd like to, from CAD/CAM to whatever you would like. And the advantage also that you will have a reduced prosthetic space, depending if you make a cemented or screw retained restoration to 4.5 to 3 millimeter. 3.5 millimeter is enough from bone level to the opposing teeth. Now let's focus on surgery. Most competing companies have very complicated drill protocols. You can see how Alphadent is working with their kits, how complicated it. No wonder why you have to learn it. Then different other companies try different solutions, but most of them come up with very complicated trays, and depending the complication, what of their implants are you using. And the contrary, IBS has a very straightforward, very simple tray, which is easy to see and doesn't have too much instrumentation. When we come down to drilling protocol, other companies do use this very complex trays because they have a very complex protocol. They usually have a primary burr, and then they use several types of series of burrs to burr to the whole volume of the implant. Then they have a special burr to remove the crest. Then they have to tap, and finally they make a form drilling maybe and insert the implant, which only is different settings on your machine, making the whole thing more complicated. And this is the drilling protocol from different company. You see that you still need a series of drills. This can be in some cases simpler, some cases more complicated, but this is a very time-consuming and very complicated procedure. In the case of Magic drill, we have a very simple box. We have a very simple instrumentation and a very simple use for that. First, we'll use the pin drill, drill in our guides, make a CBCT scan, check for the aim, then use a special hole drill, which is the Magic drill, drill to the angle and the depth which we determined on our control CT. Then we check the depth, remove the depth, we make a form drilling with a final tap and insert our implants. When we step back a little bit and we look at it, I'm working because I'm a traveling surgeon with several implant systems. And when you begin to use a new implant system, you have to be aware how it works, and you have to drive them, insert them, and use them a bit differently than usually you do with cars. You can drive a car, you can drive an SUV, you can drive a Tesla, you can also drive a Ferrari, but to get the most out of the Ferrari on a track, you need different drive skills than normally would use. Also, you have to know the limitations of your cars. Maybe this is the fastest, but it will not take you anywhere, especially if you have dirty roads. Let's go back to implant design again. In case of implant micro and micro design, displays this significant role in overall success. Its physical and physicochemical characteristics determine the osseointegration, the load transfer to bone, and also how it is best to insert a given implant, its relation to bone and the surrounding tissues, and also the prosthetic possibilities. We always have to look at it as a whole system, including insertion protocol and the requirements for insertion, which can be very different between certain systems. This will determine the healing protocol as well as the possibilities of prosthetic rehabilitation. Traditionally, we have a drilling protocol, which I mentioned you. We have a pointing drill, then we have one drill, and we have a series of drills which still reach the diameter of the implant. In case of the MAGICORE implant, we have a first drill, then we tap, and finally we insert our drill. It's much, much simpler. If you look at the literature, it also supports that simplified drilling presents significantly higher initial bone contact after a week, which is a big advantage of better healing. Also, the simplified drilling protocol produces the similar or less heat than conventional protocol. And my third article says that low-speed cutting procedures do generate little heat, and consequently, osteocyte viability is maintained. The lack of irrigation, coupled with the unique design of the cutting fluids, channels into the osteotomy autologous bone chips and osteocoagulum that have inherent osteogenic potential, greatly increasing our immediate postoperative healing. We have a hollow drilling, drills which allow for higher speeds. First, we drill with this, then depending on the hardness of the bone, we remove the core, and finally, we use the final form drill. We can use a small aiming device that goes in the same axis as we made our initial drilling. And you have to remember that this protocol was made early. No will now come up with the N1 with a similar protocol, but MAGICORE was there from 2013. And this came out last year already. Let's go back to implant thread design. When the implant site is prepared, we need to select the right implant. Selecting an implant with thin rectangular thread reduces the bone trauma during insertion. This eliminates the bone compression. During loading the implants, the thin magic thread, the matching elasticity of the thin threads transfer load to bone with less stress. Selecting the right implant thread will have a favorable stress distribution. There will be no shearing forces by the transferring load to the bone. Due to the mechanical qualities of the thread design, we achieve primary bone healing. There will be no bone chipping and condensations. Physical properties of the insertion are not naturalized. There will be little no chance to microfractures and shearing forces during mastication. We also gain a good initial stability by achieving morphologic contact between the bone and the threads. Implant with a thin thread is recommended for soft bone according to three-dimensional finite element analysis. If you look at the implant thread design, we have to know that the interthread bone, in the case of a traditional triangular thread, will damage the bone. And because this interthread bone is damaged, we have to still have 1 millimeter of undamaged bone on both sides from the side of the threads. Because this initially damaged bone first needs to resolve, and only then will we have new bone. A new method of securing primary stability is needed because the interthread bone should not be damaged during placement. We will reach stability with morphologic contact. For this new thread design was needed. When we design the system well during surgery, the periosteum will not be detached and cortical bone is not exposed. We can perform flapless surgery with much less post-op morbidity and no bone resorption. The bone and the implant should join like the Lego bricks. Dental implant threads transfer occlusal force onto the alveolar bone like gears. If the load resistance is not the same between the two gears, the weaker of them will break. When comparing the resistance to loading forces of bone and titanium is 1 to 9, the thickness of interthread bone should be 9 times thicker than the titanium thread itself. When comparing the resistance to elastic forces of bone and titanium, the ratio is 1:10. The thickness of interthread bone should be 10 times thicker than the titanium thread. The required bone width is 2 mm greater than the diameter of the body of the fixture. And this is the difference that in this case, because the interthread bone is not damaged, we measure it from the core of the implant. That's why we will need much less bone from the side of the thread, which is given as the diameter of the implant. Application of the concept of matching of physical properties between interthread bone and thread. This titanium bone ratio is patented. To fulfill the requirements, the titanium thread must be rectangular. In shape, its thickness must be less than 0.15 millimeters. The forces transferred to the bone are controlled. According to finite element studies, if you take a look at the case of traditional implants, most of the forces are transferred to the bone on the coronal 3 to 5 millimeters, and this is usually which results in cortical bone resorption. But in the case of a magic fin thread, you will have an even transfer of forces during the whole length of the implant. The placement method also varies according to implant design, and bone width, which is 2 mm greater than the diameter of the fixture, is required in the case of traditional implants. In the case of magic fin thread, we have to perform a fit drilling. We use a basic preparation for that because we use hollow drills. We can use high RPM. We do not need to do the usual pumping, and we use intermittent force. We maintain our direction, and we have to reach our desired depth. Once we are finished with that, we do a fine preparation with low speed, high torque, and we should not apply any vertical or lateral force. We have to match the path of the basic preparation, and we have to keep in mind that this will be the path of our implant insertion also. We do insert the implant by hand, which should match this axis. The primary stability in the case of a magic fin thread will be not determined by the insertion torque, but by the fit drill. We also need to immediately reach the predetermined depth with our insertion. Because the interthread bone volume is large and we have fit drilling, direct connection with the bone healing is fast and primary stability is high. If you take a look and compare the magic implant to traditional implants, you can see that how bigger is the volume of the bone which we are in contact with compared to two traditionally similar sized implants. And let me show you a case. You can see here is, it will be an immediate implant case. It's a courtesy of IBS Implant. They had these two teeth extracted. The red line is the soft tissue. The yellow line is the hard tissue. The implants were inserted. And if you compare the original bone level, here the bone level, and here the bone level, you can see the bone height gain, which is unique to this implant. This is the measured gum, lateral, and the view from above, and a final restoration both in the upper and lower jaw. You can see a beautiful gum margin. On the CBCT, you can see that the bone actually grew and climbed up along the implant. What are the advantages of MAGICORE? First, the magic fin thread. It gives stability by morphologic contact. There is almost no pain after surgery because we can use minimal invasive techniques for implant insertion. We can use the implant also in our ridges. The second is the magic cuff, which is strong and gives a strong and resilient gum seal. We will have low chances of infections, and it will also maintain good periodontal health. It is a very strong connection, so we will not have any screw loosening, and we will not have any rotations. If we use a conventional triangular thread, we will apply excess damage to the bone. This is due to the triangular shaped thread. We will damage this bone, and this will lead to initial bone resorption, decreasing our initial stability. If we have a magic thread with good initial stability, which is rich that we have good and undamaged inter-thread bone, we will have a faster healing and better immediate stability. The function of the magic fin thread is to stabilize the implant, because how it is made, we can use it in narrow alveolar ridge also. We have several sizes, which is much bigger, and we have a much better selection than the competition. The stress distribution is different between a traditional and thin thread implant. We will have outstanding stress distribution. This way, the functional surface is extended, because basically we can see in a case of a normal implant, it's only the first 3 to 5 millimeters, while here we can count with the whole length of the implant. We have several sizes, both for the cuff and the fixture itself, which results much more flexibility in insertion. And if we look at the magic abutment, we have much more possibilities for prosthetic rehabilitation. The junctional epithelium will be spared. It will be healthy. We will have connective tissue adhesion. We will have a one-body structure, and the magic fin have its advantages, which is outstanding stress distribution due to its macro design, also because we have this large volume of inter-thread bone, and we will have an extended surface of bone, so we will have increased initial bone contact. And because of the surgical procedures, we will be convenient inserting these implants. So now let's go over, and I will show a couple of my cases. This was my first case. He's a 40-year-old, absolutely healthy patient. You see how much bone he had. He was missing tooth 1.5. We opted for MAGICORE. This is the intraoral picture preoperatively. First, you measure the gum. Then you drill your magic pin. Once the pin is inside, you take a control CBCT. On this, you check the angulation, the position of your pin. You also do check which size of fixture you will need. Then either you make a mini incision, or you just drill through the gum. You make your drilling. After the initial drill, you do the final tapping or foam drilling. Take your beautiful MAGICORE, which is selected by how much bone you have. That's how you select the fixture, and according to the bone above the fixture, which cuff you will select. You have 3 sizes of width for the head of the implant. This is selected which kind of tooth you want to replace with. Inserted the implant. Then you put the covers through. This is the postoperative cone beam CT. In these cases, I also always do use a post-op cone beam CT to check my results. You can see that in this case, I needed to change my angulation a little bit compared to the original one. This is 3 months after. And now let's go to the second case. This is not so recent case. It is a middle-aged male who is healthy, non-smoker. He had a good amount of bone, would have liked to have minimally invasively inserted implants. He did have some compromised gum. So one of the options was to make a gum surgery with traditional implants. But because of the minimal invasive surgery and because of the MAGICORE, we didn't need that. Drilling of the guide pin, insertion of the 2 guide pins, CBCT with the guide pins. This is the guide for the final drill, and then the control CBCT with the inserted implants, and finally the intraoral picture. The healing time will be 4 months, and after 4 months we'll load it. Thank you very much, and hope that soon we can meet in person in a different lecture. Thank you very much. Sorry, I cannot hear you.
Thank you. Can you hear me now?
Yeah, sorry.
Sorry, there was some technical problems with my microphone. Thank you very much, Dr. Zoltan, for such a detailed explanation on the MAGICORE, and especially thank you for sharing your cases. It was very interesting, really something new approach in that field. I really appreciate, and as you said, hopefully we will have a chance to meet again soon in a live lecture.
Thank you.
Thank you. So without taking any breaks, let's go to our second speaker, Dr. Chamachot Chumpon, Doctor of Dental Surgery, Mahidol University, postgraduate in oral surgery, Master of Dentistry. He is a senior consultant at Princess Mother National Institute on Drug Abuse Treatment, national speaker of IBS Implant and Academy of Minimal Invasive Implantology in Thailand. He will have his lecture on the one of our most important protocols, the feed drilling and feed implantation. Dr. Chumpon, can you hear me?
Okay. Hi, Anwar. I hear you very well.
Nice to see you again.
Good to see you again.
Can you start your presentation so I can confirm before going to mute?
Okay, I try to share my screen now. Okay. Can
Yes.
you see my screen? Okay.
Yeah. See it perfect. Crystal clear.
Okay. Okay. Good morning and good evening, good afternoon, or good night to everyone from all over the world. I guess. Okay. It's very appreciated. It's very my honor to stay here to talking with you all to share some experience about minimal invasive technique or do the feed drill and feed implantation with MAGICORE. Okay. In fact, I have been experienced for conventional implant for I think about 20 years. Okay, but in a couple of years, I start to know about the MAGICORE, and I found it's very, very good. I love it very much. Okay, now I'm gonna talking about the case. I'm in Thailand. Okay, in Thailand, I have to tell you that for now, have no COVID new case at all for now. So I hope you maybe in the next few months when Thailand is free from COVID and the other can come here, okay, to talking together. Okay, but now we can talk by use online first, okay. Okay, for the surgical technique, in fact, you may know from the first lecturer already, my friend from Hungary, okay. The purpose of to do the surgery about the MAGICORE, that we have to make the shape of osteotomy inside the bone as the same as the shape of the implant itself, because we use morphology contact system. We have to preserve the interthread bone here. That's right. Because interthread bone is very, very important to make a stability and make the healing is very fast. It really can preserve interthread bone. Okay, so to do the surgery, we have to do the flapless and we do minimal invasive, minimal destruction to the bone is around here. Okay, I will talk to you by learning from the case, okay? Okay, the first case that I used to sharing with you is the first case is number 46 in this area, okay? From this case, you can see the height of the bone to the inferior alveolar nerve is okay. It's very good for sharing the knowledge, okay? And the bone width is very good, okay? But to do the MAGICORE system, just bone enough is not enough, okay? But the gingiva is very important in this part, because when you want to put the implant here, we use a bone center concept, but we use flapless technique. So the gingiva around in this area is very important. We have to put the implant in the area that the tissue is very stability, no mobility at all, okay? We have to check, and that area that we want to place the implant, the gingiva is okay or not. To check, let you see in the picture, if you want to put an implant here in the mid-crestal here, the red arrow here, you have to check by probe, punch around the implant at the buccal side in this area, about 2 or 2.5 millimeter from the center of the bone or center of the implant in the future. The tissue in this area should not move, okay? But if the tissue is moved, you have to change a little bit, change the location to find the more proper location to put the implant, okay? In this case, you can see the point A is the mid-crestal, is the center of the implant in the future that I plan to do the implantation here. And the point B is about 2 millimeter from the point A. So I checked the mobility of the gingiva and then found that, okay, point A is mid-crestal and point B is not moved. Okay, that means point A is very beautiful and sweet spot to do the implantation, to do the first drilling here, okay? But before to drilling, you have to check the bone quality first. In the surgical kit of MAGICORE, you have a magic split, okay? Magic split, you can use the instrument by hand, push into the bone at the center of the crestal that you want to put the implant here. if the bone quality is D1 or D2, maybe you cannot put anything down in the bone. But in D4 bone, you can push by hand. The magic speed will go down into the bone maybe until 8 or 10 millimeter in the bone. So that means if that occur in D4 bone, maybe we cannot use the drilling technique. We have to change to use the leech split technique. Okay. But for this case, it's okay. I think the bone is about D1 or D2 bone. And before to put the drilling in that area, because you cannot see the bone inside, because we use a minimal invasive, a flapless technique. So you have to imagine about the bone shape and the bone angulation. You can use your finger palpation around that areolar bone, and maybe you can use the needle of the injection silings punching around this area to determine the shape of that bone. So you can put the implant in the mid-crestal or in the concept of bone center concept. Okay, in this case, after I palpation the bone and the bone is very big, so I can drilling the first drill here. We call pin drilling. Okay, pin drilling. We use this machine to drill until we go penetrate to the cortical bone about 4 millimeter in the bone, not more than that. Okay, and I love is this machine and this equipment very much because it's easy to see the angulation, easy to make the center to the bone, and easy to drilling. We use 2000 RPM to use this machine, okay, to use this instrument. After we drilling the pin drilling at the mid-crestal already, okay, check again. Point A is the determine the center of the implant, and point B, we check that the gingiva not move anymore, okay? After you use the pin drill, okay, inside the bone, we use the guide pin. The guide pin, a little yellow one here, put in the hole that you just make it. This guide pin can help you to do the next step of drilling. The next step of drilling, but the next step will drill in the same angulation around here. The same angulation without error, without more angulation to other direction. Is very useful. But after you put the guide pin inside, before you use a magic drill to drill around this the guide pin, you have to check an X-ray first that the angulation that you put the guide pin inside is correctly that you prefer or not. Usually I use only plain film, but in some case, if you have a CBCT, you can use BCT to determine in 3D angulation. But if you have no CBCT, okay, no problem. You can use your palpation about the angulation of the bone, and you use just only plain film. We can do the MAGICORE system. In this case, we use only plain film to determine the angulation of the pin. And you can see I like this angulation. So next step, I use the magic fit drill. But before to use the magic fit drill, we have to determine the length of the drill first, because in the normal or conventional implant in the bone level, if you want to put 9 millimeter implant, okay, we just drill in the bone 9 or 10 millimeter from the crestal bone. But this is a tissue level. We don't open the flap, so we have to measure from the gingiva. So the gingiva height is very important to know. We have to measure the gingiva height around the guide pin. 4 point around the guide pin. Okay, 4 point. I use gingiva probe around here. 4 point around the guide pin. In this case, when I used the probe to measure the gingival height and found that on the buccal side 2, the mesial side is 2, lingual 2, and this time 3. I'm always prefer to use the buccal gingiva to determine the length of the cuff and the length of the drill. Because you know, if the gingival height is 2, usually I use this gingival height to determine the cuff height should be 2 millimeter at the same of the gingival tissue, okay? Because this is in non-aesthetic zone, so I prefer to use the gingival height to determine the magic cuff height, the same length, the same depth, okay? And the drill depth will use the fixture length, okay, maybe here, plus with the soft tissue thickness here will be the fixture length. And to placement depth, in the positive non-aesthetic zone as a posterior tooth, we prefer the margin to equal to the gingival level and left the pores about 2 millimeter up above the gingival level. But in the aesthetic zone, it's a little bit different from this theory, okay? Because in the aesthetic zone, we don't want anyone to see the margin of the crown around here. So in the aesthetic zone, we have to choose shorter magic cuff by use the soft tissue thickness minus 1 millimeter. So we can choose the cuff height a little bit shorter than in the posterior or non-aesthetic zone. Okay, but the drill depth use the fixture length and soft tissue thickness the same, such as we want to use the fixture 9 millimeter and soft tissue thickness is 2, so we use the depth drill about 11 millimeter. Okay, we see in the next slide. Okay. But because this tooth, I use the non-aesthetic zone, so I prefer the gingival height should be equal to the margin of the cuff and left the pores 2 millimeter above the gingival level. And the cuff should be the same height of the gingiva. So in this case, you can see we measured the buccal gingival height is 2. That's mean for gingival height is 2, so the cuff should be 2, the same. But in the aesthetic zone, the cuff may be just 1 millimeter shorter than the cuff. Okay, and in this case, I prefer to use 9 millimeter length and 5 millimeter diameter. And the cuff height we use 2. That means the drill depth should be 9 plus 2 equal 11 millimeter. Okay, so this here I use magic drill depth at 11 millimeters. Start from the surface of the gingiva, not the bone, from the gingiva. Okay, this is a model for drilling magic depth drill. Okay, at first you can see that we have a magic the guide pin inside, so we can engage the magic drill around it that maintain the angulation of the implantation. It's very good. And after that, we use a spoon excavator to remove some excess bone. And sometimes have a little bit bone around here. You can use the depth drill. Little bit drill can make the depth confirm to the 11 millimeter for this case. Okay, you can see the real thing. Guide pin here and use the magic drill. At first, we have to drill a little bit, about 4 millimeter in the bone to bring up the guide pin out first. Okay, and left about 4 millimeter bone hole inside the tissue. Okay, like this. But in this picture, the depth of the hole is about 4 in the bone plus 2 gingiva, about 6, not 11. So you have to drill more in the next. We use the ruler here to measure, confirm which mark is 11 millimeter. So we drill in the case until to the mark, and we use the buccal gingival height to be the marker of this case, and that drill is 11 millimeter. And after that, use a spoon excavator to remove some excess bone, and again use the depth drill to make sure the depth of the hole is precisely 11 millimeter from the gingival margin. Okay. Okay, now we got the 11 millimeter depth of the hole inside the bone and gingival tissue already. So next step, we have to make the morphologic contact. We have to make the shape of the hole the same as the implant that have a thin thread around it. Okay. To make this occur, we will use a magic tap drill. Okay. Magic tap drill. At first, we used by the micromotor first at about 40 Newton torque. If when you use the motor tapping inside, if it stop at 5 millimeter, that means it's okay. You can now change to use the final fixture put inside the bone. But sometimes when you see that the bone is very dense as D1 bone, maybe when you use 40 millimeter, I'm sorry, when you use 40 Newton torque, the drill stop before reach the 5 millimeter within the bone, so that bone is very, very dense. So can use the hand instrument with the latches to rotate more until it reach about 7 millimeter in the bone. Okay, this is a magic pin that we use for easy to use a magic tap drill to make a morphologic contact, but you can see it just had a stop about 3 millimeter inside to prevent more tap into the bone. Okay, at first we put the magic pin into the hole first, and the magic pin show the guide a little bit for the magic tap drill, and after that we use a magic tap drill that have a hole at the tip of the drill, cover the magic pin and tap drill. Use 40 Newton torque until we reach a 5 millimeter in the bone. Okay. And after that, you can use the MAGICORE insertion by hand. I confirm by hand. Don't need any 40 Newton force, 35 Newton force. No need for that force to torque. We just use hand, and sometimes use a ratchet a little bit. Okay. Okay. And after you use a latchet and put the gingival margin is the same at gingival level, and left the pores 2 millimeter out of the gingival level because it's a prosthetic, not a non-aesthetic lesion. But in the aesthetic zone, maybe a little bit deeper, about 1 millimeter. Okay. In this case, it start from 6 February. Okay. And after that, 3 months about later, you can see a little bit the gum a little bit unclosed around here, and make a impression coping and put the short abutment by screwing and cemented the crown. And you maybe notice a little bit screw hole that I like it to left the screw hole like this and filling with the composite resin. Okay. So it have problem or something have to do in the future, we can uncover the composite resin and unscrew again. Okay. Case number 2 is number 46 and number 47. Okay. This case, I measure the bone height is okay. It's about 11 millimeter, both tooth, both teeth. Okay. This case I use CBCT and confirm. Okay, the length of the bone to the IAN. At first, I used the guide pin here, and you can see the angulation. I don't like it because it points to the root of the femora. So we can change a little bit. We can change a little bit position and angulation. So, and next we can do the same on the second guide pin to the same direction. So we can collection by X-ray. And after that, you can see in the mouth and use this guide pin, bring the magic fit drill and drill in the bone as we decide the depth of the bone and depth of the cuff. Okay, and we can put the implants very, very precisely part as we imagine. Okay, this is I want to share about you about the drilling technique and how to put the implant inside the morphologic contact with the bone without no force. And this will bring up the very, very fast healing because we don't broken interthread bone at all. So only not more than 3 months we can do the prosthetic part simultaneously. Okay. Conclusion for the MAGICORE, we have new concept of prosthetic treatment method. We have better and good to junctional epithelium adhesion and both on connective tissue adhesion. And because of the magic fin thread like this, so more stability, and the first time we put the implant in without breaking any bone around the implant. Okay, this is the benefit of MAGICORE that I share for you today. Okay, if some of you have some question, maybe ask to me later. Thank you for listening to my presentation. Okay.
Okay, Dr. Chumpon, thank you very much for your presentation. Really nice to see the follow-ups of your cases, and I hope in the real near future we'll see like even more cases of yours.
Okay, thank you very much, Anwar.
Thank you. See you soon. And now the last but not the least, Dr. Burhonsyi Vladislav Valerievich from Ukraine, Doctor of Dental Surgeries, member of Ukraine and international. Give me a second, I forgot to share my presentation. My apologies. So, member of Ukraine and international professional dental associations, one of the authors of Practical Manual, Modern Aspects of Treatment and Rehabilitation in Dentistry, holder of dentistry seminars and hands-on sessions, certified speaker of AMI and IBS Implant Korea. Dr. Burhonsyi, can you hear me?
Yes, I'm hearing you.
Nice to see you.
But how to show my presentation? Do you hear?
Yeah, we can hear you, but we still didn't see your presentation. Yes.
And now?
Yes, we do. Crystal clear.
Hello. Greetings from Kiev, Ukraine. And today we begin with the implant MAGICORE and soft tissue. On this slide, you can see the perfect combination of soft tissue and the crown. And this slide shows us the inflammatory process that come after the operation with the suprastructures. This is the evolution of peri-implantitis. And now it's a negative scenario for the patient and for the doctor. In the result, we come to understanding of the importance of biological words and of soft tissue near the implant. Implant MAGICORE gives us opportunity to save soft tissue and to prevent us from bone atrophy. As you can see, bone level implant, we can compare bone level implants with MAGICORE. And we can see that the bone level implants get a deep pocket in which begin inflammatory area, and it will be in the middle of this inflammatory area will be connective tissue, and as a result, this will be accelerate of aging of periodontium, and soft tissue atrophy will go on, and go on will inflammation around the implant. And on the right side, you can see implant MAGICORE, and with the variable ways of the neck. And we receive there a good connective tissue, and as a result, healthy periodontal condition, which is similar to the periodontal condition of the teenagers. On this side, over to IBS company, we have an implant with different neck lengths, and it can be used in different clinical cases, combining different neck with the different clinical situation of the bone. And we have a neck of 2, 3, 4, and 5 millimeters. And now let's look at the response of soft tissue to the implantation with the conventional bone level implants, and compare it with the response of soft tissue of the MAGICORE implant. And when we install the implant, and after our work with the various versions of superstructures, epithelium can penetrate soft tissue near the implant, and epithelium move along the surface of implant, and as a result, the area of connection of soft tissue and the implant reduced. And implant MAGICORE saved us from all with negative perspectives. In the implant MAGICORE, we receive complete adhesion of the epithelium and connective tissue, and the biological waste is completely preserved. That means that biotype does not change in any way, and even it become more better and denser. In convenient bone level implants, we have such problem as a micromobility of the crown, which is become as a result of changing pressure, and it forms so-called pump effect. And here on this slide you can see it. And it is the one of the case of periimplantitis. It's bone level implants. And now MAGICORE completely devoid us from such negative aspects. On this slide, we can see the example of thinning of soft tissue around the crown. And these small slides showing different prosthetic stages of the relationship between the implant MAGICORE and the bone. And we can see stability of bone structure for a long period of time. So we can understand the conditions that are necessary to prevent changes in gums, and you can read them on this slide, maybe without of my brutal accent. And now it is a small clinical example. It is 48 years old woman. Implantation is planned in area from 12 till 24th teeth. It is a clinical situation from different points of view. Now, pay attention to the condition of soft tissue and to the condition of the bone. Here we have section of computer tomography, which show a combination of implants and bone structure. And we can see how the implant clearly combined with the bone and performed by the bone structure. And the neck of the implant continues the bone and becomes the basic to developed and retention the soft tissue. And each of the implants harmoniously located in its place. This is the clinical picture after the manipulation. And also you can see the plastic surgery of frenulum of the upper lip. It is a week after the manipulation, 1 week. It is a stage of temporary prosthetics. We can see the good condition of the soft tissue here, and a harmony combination of pink and white aesthetics. It is after 5 months, and we can see the bone structure stable around each of the implant. 6 months clinical situation. It is after 9 months. X-ray picture shows us complete stability, and now it will be next implant. Next. And clinical situation, 9 months. And IBS company offer us maybe it's an ideal implant for working with bone and soft structure. And here you also can see advantages of MAGICORE, and previous lectures show you this picture, and now you can also read yourself all advantages of MAGICORE without my accent. Next topic of our presentation for today is the MAGICORE and the corner crowns. It's a picture, and we look a little into the past. And now we must think that we standing on the shoulders of our fathers and fathers of our fathers. And we see in the left top the ivory implants made many centuries ago. And also we can see bone tooth. And in the bottom we can see an implant used for a long time in Ukraine dentistry. On this slide, I want to show you a different view to the same subjects. For example, it's a view, one of the views on our planet. It's another view. Maybe it's a view from Seoul, maybe from Hanoi. It is maybe from Ukraine. And now we are going to the difficulties that arise in bone level implants with the soft tissues, and how are they solved with the help of modern implants. In most cases, the abutments has a height of not the less 4 millimeters, and often it's not harmonized with different shapes and size of crowns. Also, that can be bite-oriented implant is on the left side of this slide. And on the right side is existing from the bone orientate. And what happens with active cone implants in this situation? The implants are the majority of the modern implants on the market, and they have an overstrain of the lower part of the body, and due to overload of the cone. But an IBS company formulate for itself maxima that all connections must be strong. It's a maxima of IBS company. And they make an implant MAGICORE, and MAGICORE solved all these problems. And MAGICORE implant has the minimum abutment height on the market, and it has a variable length of the transgingival part. Due to single body connection of the implant with the abutment, there is no possibility to formation a micro gap and to penetrate it with microflora and to develop of the inflammation in implant MAGICORE. The connection of the abutment with the crown is stimulationally external and internal, and this has important conveniences. See how the MAGICORE looks on the cut. The connection is integral. On the slide, it is compare MAGICORE implant with the bone level implant, and abutment size reduced, and it is a great opportunity to change the inclination of crowns, and now it is up to 50 degrees versus 35 degrees at the bone level implants. And it's no problems with the lateral forces, loosening of the crown, and is this problems with the bone level implants. It is this slide illustrates us direction of the force in a MAGICORE implant. In there is no risk of fracture, and the MAGICORE implant is suitable both for the cement and screw fixation. This slide shows an example of combination of bone offering and MAGICORE implants. It may seem that distal implant in the first quadrant is too angled, but this is an attempt to avoid long and difficult manipulation with the sinus. It's imprinting stage. And final configuration. And this configuration is absolutely functional. Next, our topic is combination of MAGICORE and narrow ridge. Different atrophy questions, and there's very difficult and controversial answers. GBR, Tamiya, design changes. Also, different questions. And one easy answer. And this answer is MAGICORE. And also, we had to remember that functionally of orthopedics depends on the surface of implants and bone structures. And this is characteristic of the effects of the triangular thread on the bone during implantation. The internal bone is surely injured, and it's complete resorbed with a long partial restoration. That means that we need bone weights more than 2 or more of the 2 millimeters larger than the diameter of the implant. And if we want to install 4 millimeters implant, we need bone at least 6 millimeters. IBS company made a study and found that the ideal combination of physical properties of the interturn bones and titanium is 1:8. That is, if you take a thickness of rows is about 10 hundredths of millimeter, you need the interturn step about 1 millimeter. And MAGICORE thread don't destroy the interturn bone, and we can calculate here the diameter of implant which we need to with bone. And it means that in case of 4 millimeter, we need only nearly 5 millimeter of the bone. And here we see that the MAGICORE implants holds the load along all its length, and all its surface is functional. And the area of biological contacts with bone is larger than from the implants of bone level. Thanks to this, we can use a narrow implants. At the same time, we remember that we have a variable neck length. And which we can select from for the different cases and combinations of hard and soft tissue. and our implant maximally matches to the various shape of the bone. Here's the same cases, but now we will consider it from the point of view of a narrow bone. And let's look to the area of 12 teeth. The bone is about 4 millimeters, and we see the installed implant with a diameter of 3.5 millimeters. Thank you. That's all for today. And this is the view of Seoul. And it's my beautiful view of Seoul. It's my favorite city where I have a lot of friends. Thank you.
Thank you, Dr. Burhonsyi. That was really nice. Actually, I would like to really personally thank you for sharing us that there can be different approaches and different views on one single subject. And your way of approach, really, it was something that really touched me. Thank you very much. And I hope we will be able to meet you soon.
Yeah, thank you.
Thank you.